Yes, Shilpa, you can go. Yes, good morning and welcome you all for another edition of Online Anaesthesia, a postgraduate teaching on Zoom platform, sponsored by 2April and hosted by A1 Logics. Today I am very glad to welcome and introduce two legends in our Online Anaesthesia forum. The first speaker, Dr. Aruna Parameswari. I like to introduce her. He is the professor and head of Department of Anesthesiology, Pain Medicine, Sri Ramachandra Institute of Higher Education, Chennai. She has held various positions. She is the Vice President of AOA, Specialist Board Member of DNB, Section Editor of Journal of Anesthesia and Clinical Pharmacology, and Governing Council Member of RSAACP. She has undergone special training in anesthesia and postoperative management for cleft and craniofacial surgery from Texas, USA, from Medical City Hospital of Dallas. And she has published 24 research papers with more than 130 citations. She has written 6 chapters in the Stolting Coexisting Diseases. She is the adaptation editor of Stolting Coexisting Diseases, South Asian edition. I have listened to her many lectures in the past. At the end of each lecture, I used to get a feeling as if I have completed reading a chapter of a textbook. She used to give so much of information in her lecture. So we are eagerly awaiting to hear your lecture, madam. Over to you, madam. Shilpa.
Inhalational anesthetics. Now, the inhalational anesthetics are different from most other drugs which we use intraoperatively. These are gaseous. They are administered only by inhalation, and they are taken in and eliminated through the lungs, through the alveolo-capillary membrane. This makes their pharmacokinetics very unique. Why do we need to know about the pharmacokinetics of inhalational anesthetics? Let us look at a few clinical questions. Why is pediatric inhalational induction faster compared to adult inhalational induction? Why do obese patients recover much quicker with desflurane compared to sevoflurane, especially with prolonged anesthesia? Why is inhalational induction with sevoflurane faster when we add nitrous oxide? Why do we have to use 100% oxygen at the end of a procedure whenever we have used nitrous oxide to prevent diffusion hypoxia? To answer all these questions, we need to understand the pharmacokinetics of inhalational agents. So in the next 30 minutes, I will be taking you through the physical principles which we need to understand to know inhalational anesthetic pharmacokinetics. Then I'll take you through uptake, distribution, and elimination of inhalational anesthetics and the factors affecting each of these steps. And then we will conclude with some take-home points. Looking at the physical principles, the aim of inhalational anesthesia is to achieve a particular level of anesthetic concentration or partial pressure in the brain. So the anesthetic level can be described in terms of partial pressure or in terms of concentration. What is important to remember is equilibration happens in terms of partial pressure. So the alveolar partial pressure equilibrates with the arterial partial pressure, which in turn will equilibrate with the brain partial pressure. But what we set on the vaporizer is a concentration. So how do we relate these two terms, partial pressure and concentration? For this, let us assume there is 1.5% isoflurane in a closed container like this. At sea level, the total pressure is 760 millimeters of mercury. So what is the partial pressure exerted by isoflurane? We just need to multiply the fractional concentration by the total pressure. So 1.5% isoflurane is 1.5 by 100 into 760, which will be 11.4 millimeters of mercury. So 1.5% of isoflurane is the concentration, and 11.4 millimeters of mercury is the partial pressure of isoflurane that is exerted inside this container. Now, let us assume this gas-filled container is actually in contact with the liquid and is separated by it from a permeable membrane. Now, the gases will continuously move into the solution and dissolve in the solution. What will be the concentration of the gases in the solution depends on two factors. One is the partial pressure above the solution, according to Henry's law. That is one of the determinants of the amount or the concentration of the gas in the solution. And the second factor is the solubility. So how much of anesthetic is dissolved in blood or how much of anesthetic is dissolved in tissue can be determined by knowing these two factors. What is the partial pressure and what is the solubility? Concentration of anesthetic in blood or tissue depends upon the partial pressure and the solubility. Now, solubility is described in terms of partition coefficient. So solubility in blood is described as the blood gas partition coefficient. And solubility in tissue is described as tissue blood partition coefficient. It will be any tissue. For example, if you're talking about fat, it will be fat blood partition coefficient. If you're talking in the brain, it's the brain blood partition coefficient. If talking in the muscle, it is the muscle blood partition coefficient. So what do we mean by this partition coefficient? It's nothing but a ratio of the anesthetic concentration in two separate but adjacent compartments. Let us see this in more detail. Let us look at two compartments, alveolar gas and pulmonary capillary blood. There is 100 ml of gas and 100 ml of blood. Now say we had 2% of halothane, which means there is 2 ml of halothane for 100 ml of alveolar gas at a partial pressure of 15 millimeters of mercury. Now when the partial pressures equilibrate, the partial pressure of halothane in the blood will also be 15 millimeters of mercury. So at equilibration, what is the concentration of halothane in the blood? To answer this, we need to know the blood gas partition coefficient of halothane, which is 2.4. So what does that mean? It means blood holds 2.4 times the amount of anesthetic in the alveolar gas. So if 2 ml of halothane is there in 100 ml of alveolar gas, 2 into 2.4, that is 4.8 ml of halothane will be there in a similar volume of blood. Now, if you translate this to the less soluble agents, say look at sevoflurane 2%, which has a blood gas partition coefficient of only 0.65. Each 100 ml of blood will now hold 1.3 ml of sevoflurane. Similarly, for desflurane, this number will be 0.9 ml. So what does this tell us? Higher the blood gas partition coefficient, more is the concentration of anesthetic that is dissolved in the blood. Now, since more anesthetic is dissolving in the blood, it will take longer for the alveolar partial pressure to build up and equilibrate with the inspired partial pressure. And so induction will be slower. So to summarize the physical principles, inhaled anesthetics diffuse from the alveoli to the arterial blood and from the arterial blood to the tissues till the partial pressures are equal. At equal partial pressures, the concentrations in the different compartments are different, and that depends upon the solubility of the anesthetic in that particular compartment. The compartments of relevance to us are the alveoli, the arterial blood, the tissues, and the mixed venous blood. Now let's move on to uptake. So what do we mean by uptake? Uptake and distribution just refers to a series of transfer steps from upstream compartments with higher partial pressure of anesthetic to downstream compartments with a lower partial pressure of anesthetic agents. Now, what are these steps? The first step is anesthetic molecules move from the anesthesia machine to the breathing circuit. The second step is from the breathing circuit through alveolar ventilation, they are carried into the alveoli. In the third step, from the alveoli, they move to the arterial blood. And in the fourth step, from the arterial blood, they move to the tissues. These 4 steps affect induction. The next 2 steps affect recovery, and they consist of movement of anesthetics from the tissues back to the mixed venous blood, and from the mixed venous blood back to the alveoli, from where they are exhaled. Let's look at each of these now. So the first step is from the anesthesia machine to the breathing circuit. Now, the delivered concentration is going to depend upon the amount of the fresh gas flow and the vaporizer setting. Now, this delivered concentration is going to be transferred or moved or pushed into the breathing circuit by the fresh gas flow. So, this process by which the breathing circuit is filled with anesthetic gas is called as wash-in of the circuit. How long will it take for the circuit concentration to become equal to the set concentration on the anesthesia machine? So this equilibration time is described in terms of time constant, where the time constant is given by capacity by flow. Here, what is the capacity? It is the volume of the breathing circuit. And what is the flow? It is the fresh gas flow. So if you look at the volume by flow, volume of breathing circuit by volume of fresh gas flow, let us assume the volume of the breathing circuit to be 6 liters and the fresh gas flow to be 6 liters. So 6 by 6 will be 1 minute for one time constant. Now, one time constant is the time it takes for 68% equilibration. 86% equilibration, it takes 2 time constants. 95%, 3 time constants, and 98%, it takes 4 time constants. Since one time constant was 1 minute, in 4 minutes, the circuit concentration will reach 98% of what concentration we set on the anesthesia machine. Now watch carefully. If we decrease the fresh gas flow now from 6 liters to 3 liters, now the time constant will become 2 minutes instead of 1 minute. So one time constant is 2 minutes. So 4 time constant will now be 8 minutes. So for the same breathing circuit, which is 6 liters, to achieve 98% of the delivered concentration, the time is doubled if the fresh gas flow is halved. So the fresh gas flow is an important determinant of the speed of induction. So if you compare 6 liters versus 12 liters versus 3 liters per minute, what you see on the x-axis is minutes, and what you see in the y-axis is Fi by Ft. Fi is the inspired or breathing circuit concentration. D is the delivered, that is the set concentration on the anesthetic machine. You see that when the fresh gas flow is very high, rapidly the breathing circuit concentration will reach the set concentration on the machine. If the fresh gas flow is low, this process will take longer. So it automatically translates that higher the fresh gas flow, faster the inhalational induction. Similarly, priming the breathing circuit hastens induction, because before the onset of anesthesia, we are already equilibrating the breathing circuit anesthetic concentration with what is set on the anesthetic machine. Now, moving on to the next step is from the breathing circuit to the alveoli. Now, again, here we have a time constant. The only difference here is the volume we talk about here is the functional residual capacity, and the flow now here is the alveolar ventilation. So if the FRC is low or the alveolar ventilation is high, induction will be hastened. If you compare for less soluble and more soluble agents, what you do see is that the effect of ventilation is more pronounced for more soluble anesthetics. Moving on to the third step, from the alveoli, the anesthetic molecule is going to move into the pulmonary capillary blood. So this process of transfer from the alveolar gas to the pulmonary blood across the alveolar capillary interface, it's called uptake. That is, the anesthetic molecule is taken up by the pulmonary capillary blood from the alveolar gas. So what are the factors which determine uptake? The first is the cardiac output, the amount of blood flowing through the lungs, which removes the anesthetic molecule. The second is the blood gas partition coefficient, or the solubility of the agent in the blood. And the third is the partial pressure difference between the alveoli and the mixed venous blood. That is a pressure gradient which is going to drive the anesthetic molecule. Let's look at each of these individually now. So if you look at solubility, we already spoke in terms of solubility as blood gas partition coefficient. So let us compare sevoflurane with isoflurane. Isoflurane has a blood gas partition coefficient of 1.4. For sevoflurane, it is only 0.65. So what does this mean? Higher the coefficient, more anesthetic molecules are going to dissolve into the blood. So uptake is more if the blood gas partition coefficient is more. And as I said earlier, because the uptake is more, the alveolar partial pressure will take longer to meet up with the inspired concentration. So induction is slower when the blood gas partition coefficient is higher, because uptake is higher. So if you look at the solubility of the different agents, if you say desflurane and sevoflurane, they are much less soluble. So what you see on the x-axis is the time, and what you see on the y-axis now is Fa by Fi. That is, Fa is the alveolar concentration and Fi is the inspired concentration. How long does it take for the alveolar concentration to reach or match up with the inspired concentration? So if it's a less soluble agent, very little is being removed from the blood. So very rapidly, the alveolar concentration will reach the inspired concentration. For more soluble agents, it will take much longer. So this height of this plateau will be shorter for the more soluble agents. Moving on to the next factor which affects uptake is the effect of cardiac output. So whenever there is cardiac output, there is more blood flow. So more anesthetic is going to be removed. So uptake is going to increase. So this will actually slow induction. we might argue saying that the anesthetic molecule is being taken to the brain very rapidly. But what is important here is the alveolar arterial equilibration is slowed. So induction will be slowed. Similarly, on the contrary, if the cardiac output is decreased, then induction is faster. So we can have unexpectedly high alveolar concentration and hypotension. That is why lesser inhalational agent is required in cardiogenic shock. Moving on to the third factor, the effect of mixed venous blood anesthetic. Now, when we begin the anesthetic, induction of anesthesia, there is no anesthetics in the body. There is zero level of anesthetics. So what happens is there is going to be a very rapid tissue uptake of the agents, as a result of which the mixed venous blood hardly has any anesthetic agent. So uptake is very rapid initially because there is a large gradient between the alveolar partial pressure of anesthetic and the mixed venous blood partial pressure of anesthetic. Because of this gradient, there is going to be rapid movement of anesthetic or rapid uptake. Now, what happens with time is the tissues get saturated with anesthetic. So there is less and less removal. So more and more blood, more and more anesthetic accumulates in the mixed venous blood. So this gradient between the alveolar partial pressure and the mixed venous partial pressure keeps coming down. So uptake decreases with time. Now, to summarize the factors which affect the alveolar concentration, it depends upon what goes in versus what goes out. Factors determining what goes in or the amount of input into the alveoli will be the inspired fraction, which depends upon the vaporizer setting, the fresh gas flow, and the breathing circuit volume, and the alveolar ventilation and FRC. What is removing it from the alveoli will be, it depends upon the uptake, which in turn is going to depend upon the solubility of the agent, the cardiac output, and the alveolo-venous partial pressure difference for the particular agent. Now, if you look at the FA by FI curve for soluble anesthetics, you find that the curve is like this. It is not, there is a rapid rise. It is not a straight line. There is a rapid rise, then there is a knee, and then there is a plateau, which is not horizontal, but which has an upslope. Now, why is this shape seen like this? The initial rapid rise is because there is no anesthetic molecule in the FRC. There is a rapid FRC wash-in. But what happens is this is countered by uptake, which keeps removing the anesthetic molecule from the alveoli. If not for this uptake, this will be what you see as green. It will be one straight line up, and the alveolar concentration will immediately reach the inspired concentration. It is not able to reach because constantly the anesthetic molecule is being removed by the pulmonary capillary blood from the alveoli, which brings down the alveolar concentration. So this is responsible for the first knee. Now the second knee happens. I mean, this is not a horizontal plateau. It's an upsloping plateau. This is because uptake keeps decreasing with time and anesthetic keeps getting added in the mixed venous blood. So the second knee or this upslope is because of the uptake decreasing with time. Now, there are another two effects which are commonly spoken about when you're talking about pharmacokinetics of inhalation anesthetics. One is the concentration effect and the other is a second gas effect. Let's take a look at what these are. What do you mean by concentration effect? Now, it applies to conditions where you're giving a high concentration of inhalational anesthetic like nitrous oxide. So when you're administering a high concentration of nitrous oxide, there is a rapid uptake of nitrous oxide from the alveoli into the pulmonary capillary blood. Now, nitrous oxide we know is more soluble, 36 times more soluble compared to nitrogen. So more nitrous oxide leaves the alveoli and enters the pulmonary capillary blood compared to the amount of nitrogen which is entering the alveoli from the blood to replace it. As a result of which there is a shrinkage in the lung volume. So this is called as the concentrating effect, where the remaining nitrous oxide is concentrated in a smaller lung volume. So its concentration increases. Now, because the lung volume decreases, as a second step, there is augmentation of ventilation, which brings in further nitrous oxide into the alveoli and so increases the concentration. So what do we mean by the concentration effect? Higher the concentration of an inhaled anesthetic, the faster its alveolar concentration approaches the inspired concentration. So this has relevance only to inhalational agents which we give in very, very high concentration. So it applies only to nitrous oxide, and it happens because of a concentrating effect and because of augmentation of ventilation. Moving on to what is the second gas effect. Now we said a high concentration of nitrous oxide increases high inspired concentration increases the alveolar concentration of nitrous oxide. Now the effect of nitrous oxide on another vapor is called the second gas effect. So when you look at this picture, you see that there is nitrous oxide, oxygen, and 1% isoflurane. Now rapid uptake of nitrous oxide causes concentration of the rest of the gases in a smaller lung volume. So because half the nitrous oxide is removed, you find that what was 1% isoflurane has now become 1.7% isoflurane because of the concentrating effect. Now, because of augmentation of lung volume, augmentation of ventilation, there is the next breath, which causes further influx of nitrous oxide and isoflurane. So if you look at the final concentration after nitrous oxide uptake, the nitrous oxide concentration is 72% instead of 40%, which is called as the concentration effect. And if you look at the isoflurane concentration, instead of 1%, it is 1.4%. So this is called the second gas effect, a rapid rise of the alveolar concentration of a concurrently administered second gas like sevoflurane and halothane because of administering nitrous oxide is called a second gas effect. So this is why use of nitrous oxide during sevoflurane induction hastens inhalational induction with sevoflurane. Now there's another effect called the overpressure effect. At induction, you would have all seen pediatric anesthesia where you do an inhalational induction with 8% sevoflurane. So why do you do this? We compensate for the high initial uptake of sevoflurane by delivering a far higher concentration of inhalational agents than what we hope to achieve in the alveoli. So we induce with 8% so that rapidly the alveolar concentration will come to 2%, which is the Mach value of sevoflurane. So this is called as overpressure effect, and it is done to speed up inhalational induction. So that is about uptake. Now moving on to distribution. Distribution refers to movement of the anesthetic molecule from the arterial blood to all the body tissues. Now, just like how uptake from alveoli depends upon several factors, tissue uptake also depends upon similar factors. So when you're talking about cardiac output for uptake from alveoli, at the tissue level, it becomes the tissue blood flow. When you talk about blood gas partition coefficient for uptake from alveoli, at the tissue level, it becomes the tissue blood partition coefficient. Similarly, the alveolo-venous partial pressure difference at the tissue level becomes arterial tissue partial pressure difference. Now, tissues are classified into different groups based on the perfusion as vessel-rich group, muscle group, and fat group. The vessel-rich group, as the name implies, has a very high cardiac output, about 75%. So only few minutes is necessary for equilibration with the alveoli. The muscle takes longer, a few hours. The fat has a very low cardiac output, so it takes several days for equilibration. So if you look at the equilibration, you find that the vessel-rich groups very quickly equilibrates in just a few minutes, whereas muscle and fat is going to take much longer. The Mapleton's water analog is commonly used to describe as an analog how the distribution happens for the inhalational anesthetics. So if you look at this, the various containers are considered to be the various organs and tissues. The volume of water in these containers is actually the level of anesthetic, quantity of anesthetic vapor, and the pipe represents ventilation and circulation. So if you look at this picture, you find that the vessel-rich group is small with a big pipe. So what does that mean? The vessel-rich group is small in volume, but it has a very good cardiac output. So the supply, the circulation, or the influx of anesthetic through the circulation is more to the vessel-rich group. If you look at the muscle, it's a big container because we said 50% of the mass is by muscle. Now, fat, although it has a lesser volume compared to the muscle, the effective volume is more because most of the anesthetics are highly soluble in fat. So the effective fat volume is more. That is why the fat is also represented as a large container. Now, if you look at the poorly soluble agent like nitrous oxide, you find that all the containers are quite small. This is because not much of tissue uptake is there because it is poorly soluble. Whereas if you take an agent like halothane, you find that the containers are large. This is because it is being taken up as it is more soluble. So equilibration takes longer with the more soluble anesthetics. Moving on to the final part of the pharmacokinetics, the elimination. This consists of two steps. From the tissues, the anesthetic molecule has to move to the mixed venous blood, and from the mixed venous blood, it has to move into the alveoli and then to the exhale to the atmosphere. Now, partial pressure gradients are reversed because at the end of the anesthetic, we cut off the vaporizer. So the inspired agent concentration now becomes 0. So all the partial pressure gradients are now reversed. Now, increased ventilation, just like how it hastens induction, can also hasten recovery, provided it does not lead to hypocapnia. Because once there is hypocapnia, there will be cerebral vasoconstriction, which will prevent the anesthetic from moving from the brain to the artery. So it's important to remember that hyperventilation, if it causes hypocapnia, can actually delay recovery. But what is the difference between recovery and induction? There is no equivalent of overpressure effect for recovery because below 0, we cannot put the vaporizer. So there is no equivalent of overpressure effect. The second thing to remember is during induction, all the compartments are at 0 anesthetic. Whereas when recovery is beginning, each of the compartment, the vessel-rich group, the muscle and fat, will have different amount of anesthetic depending upon the type of molecule as well as depending upon the duration of anesthesia. So there is differential elimination from the different compartments. So it's a multi-exponential kinetics during recovery. So if you look at the effect of solubility, if FA is the expired concentration and FA0 is the expired concentration at the time you shut off the vaporizer, you find that for a more soluble agent like halothane, since it's more soluble, there is a larger capacity of the tissues to hold this. So at the end of the anesthetic, all these tissues which absorbed the anesthetic will slowly keep releasing it into the arterial blood, into the alveoli, which will slow the recovery. Whereas for a less soluble agent like desflurane or nitrous oxide, there is not much of tissue capacity to hold. So recovery is very fast. Similarly, if you look at the effect of duration of anesthesia, prolonged anesthesia tends to affect the soluble agents much more than the insoluble agents. So to answer our questions, why are pediatric inductions faster? So we said it depends on FRC and alveolar ventilation. Children have a larger ratio of alveolar ventilation to FRC. They also have different blood gas solubility because of the lower serum protein and lipid concentration. The volatile anesthetics are less soluble. And also the cardiac output is disproportionately distributed to the vessel-rich group compared to the adults. So it enhances the drug delivery to the CNS. So these are the few reasons why inhalational induction is faster in children compared to adults. Moving on to the next question, why desflurane leads to quicker recovery in the obese? To answer this, we have to look at the fat blood partition coefficient of desflurane versus sevoflurane, which is 27 versus 48. So what does that mean? Fat holds 28 times as much sevoflurane as desflurane. So especially with the prolonged anesthetic in the obese, from this fat depot, the sevoflurane will keep getting released even after shutting off the vaporizer. So desflurane is not taken up so much by fat. So recovery is faster with desflurane in obese patients compared to sevoflurane. Why diffusion hypoxia? Again, as we said, more nitrous oxide at the end of the anesthetic is going to enter the alveoli compared to the nitrogen leaving it. So there is decreased oxygen concentration in the alveoli, which will lead on to diffusion hypoxia. Next, we'll move on to a few more questions. Now, what happens when there is a left to right shunt? Let's assume there is a child who has a ventricular septal defect with the left to right shunt. What will be the effect on the speed of anesthetic uptake and inhalational anesthetic induction? Now, if you look at this, the blood in the left ventricle already has inhaled anesthetic because it has already come from the lungs. Now, because of the left to right shunt, this blood already contained inhaled anesthetic is being recirculated into the lungs. So what happens because of this now? The mixed venous blood that is going to the lungs will now carry more anesthetic. We already said that uptake depends upon the cardiac output, the solubility of the anesthetic agent, and the alveolo mixed venous blood partial pressure gradient. So if there is more inhaled anesthetic already present in the mixed venous blood, this alveolar to mixed venous blood gradient is going to be lesser, which is going to decrease the uptake. But on the other hand, whenever there is a left to right shunt, there is going to be an increased pulmonary blood flow. So because there is increased pulmonary blood flow, that will increase the uptake. So there is one factor which decreases the uptake, and another factor which increases the uptake, these two sort of balance each other, as a result of which there is no clinically significant effect on the speed of inhalational induction whenever there is a left to right shunt. But if the left to right shunt results in a decreased cardiac output and reduced blood flow to other tissues in the body, then anesthetic equilibration in these tissues, including the brain, can be slowed, which can then slow the inhalational induction. What about right to left shunts? For example, in situations like tetralogy of Fallot, when there is a right to left shunt, what happens? Blood, which is not containing any inhaled anesthetic, because this is before it passes through the lungs. The blood on the right side of the heart is blood which has not yet passed through the lungs, so it does not contain any inhaled anesthetic. Now, this blood from the right side of the heart is going to move to the left side, which carries anesthetic from the lung, this blood. And this mixed blood from the right and the left side is going to enter the aorta. So what happens? This mixing of the right-sided blood, which does not contain the inhaled anesthetic, with the left-sided blood, which contains the inhaled anesthetic, results in dilution of the arterial blood anesthetic levels. So this is going to decrease the anesthetic delivery to the brain. So inhalational induction will be slowed in conditions when there is a right to left shunting of blood. Now, what is the difference between sevoflurane and halothane as far as a right to left shunt is concerned? With sevoflurane or with halothane, with which agent is inhalational induction more slow? You find that this effect of slowing of inhalational induction is much more for the less soluble agents like sevoflurane compared to agents like halothane. This is because the blood levels of sevoflurane are as such very, very low because of the poor solubility of sevoflurane. And this low level is further reduced by the shunted blood with no anesthetic. So the effect of a right to left shunt is more pronounced with sevoflurane compared with halothane. Now let's move on to the next question. What is the blood gas partition coefficient of the different inhaled anesthetics? So nitrous oxide and desflurane, it is very, very low at 0.47 and 0.45. Sevoflurane, it is 0.65. Enflurane, it is 1.9. Isoflurane, it's 1.4. And halothane, it is 2.5. So among all these inhalational agents, desflurane has the lowest blood gas partition coefficient. So both induction and recovery will be fastest with desflurane. Among the older agents, if you look at the blood gas partition coefficient, for methoxyflurane and diethyl ether, it was 15 and 12, which is very, very high, which means they were highly soluble in blood. For cyclopropane, it was very low at 0.415. Trilene and chloroform also, it was high at 9.8 and 10.3. For xenon, it is 0.2. Moving on to the next question. Why does nitrous oxide expand gas-containing spaces? Now, if you look at the blood gas partition coefficient of nitrogen, it is 0.015. If you look at the blood gas partition coefficient of nitrous oxide, it is 0.47, which means nitrous oxide is 30-fold more soluble in blood than nitrogen. So whenever there is an air containing space, for example, like a pneumothorax, nitrous oxide tends to diffuse into this airspace and nitrogen diffuses out of the airspace. Because nitrous oxide is more soluble, more nitrous oxide diffuses into the airspace than the amount of nitrogen leaving the airspace. So because of this, either the volume or the pressure of the space will increase depending on the compliance of the particular space. Now, what are these air spaces which can increase in size with the use of nitrous oxide? Pneumothorax, pneumocephalus, intravascular air emboli, intravitreal gas bubbles, air in the inner chamber of the ear, and air in the gastrointestinal tract. Now, if we have smaller air emboli versus larger air emboli, expansion of which embolus will be much quicker or much faster when we use nitrous oxide? Now, the rate of nitrous oxide diffusion into gas-filled spaces depends on two factors. One is the local blood flow, and the second is the surface to volume ratio. So if you look at small air emboli, they have high surface by volume ratios. So they will expand within seconds with the use of nitrous oxide. So they expand very, very rapidly. The larger air emboli, they have a smaller surface by volume ratio, so they will tend to expand more slowly. So the smaller air emboli will expand much more quickly with the use of nitrous oxide compared to larger air emboli. What is the effect on gut air versus pleural space air when we use nitrous oxide? So by the same logic, compared with pneumothorax air pockets, gastrointestinal air pockets have lower surface volume ratios and lower blood flow. So expansion of air in the gastrointestinal tract will be much slower compared to expansion of a pneumothorax with the use of nitrous oxide. Now, regarding the different inhalational anesthetics, what is the percentage of metabolism of each of these agents? With halothane, it's 25%. With sevoflurane, it's 5%. With enflurane, it's 2.5%. With isoflurane, it's 0.2%. And the least is for desflurane at 0.02%. What organs are affected by the metabolic products of inhaled anesthetics? The two main toxic effects are seen in the liver and in the kidney. If you look at the liver, the commonest is the halothane hepatotoxicity, which can be of two types. It can be a mild subclinical type, which is because of reductive metabolism of halothane, or we can have the fulminant type, which is because of oxidative metabolism of halothane with formation of the product trifluoroacetyl chloride, which then reacts with hepatic proteins to form a neoantigen, which then causes immune-mediated hepatic damage. What about nephrotoxicity? In the original days, methoxyflurane was associated with nephrotoxicity mainly because of increased levels of inorganic fluoride, which were released by its metabolism. So the inorganic fluoride, which is released during metabolism of these compounds, causes renal injury, and the nephrotoxic threshold of this plasma fluoride is approximately 50 micromoles. But with sevoflurane, it has been found that there is no clinically significant nephrotoxicity even when the fluoride concentrations are greater than 50 micromoles. Now, why is this so? What is the reason for absence of renal toxicity with sevoflurane? One is the lower tissue solubility of sevoflurane, particularly in the kidney, resulting in lower intrarenal fluoride production. It's also because of lower rates of metabolism of sevoflurane compared to methoxyflurane metabolism. And it's also because of the more rapid respiratory clearance of sevoflurane from the body. So sevoflurane is not associated with nephrotoxicity, though it may be associated with increased levels of inorganic fluorides due to metabolism. Now, this about metabolism, is there any percutaneous or visceral anesthetic loss of the inhaled anesthetics, and is it significant? So there is some amount of cutaneous loss, especially so for nitrous oxide, but the amount is small. Similarly, inhaled anesthetics also pass across the gastrointestinal viscera and the pleura. So during open abdominal and thoracic surgery, there is some anesthetic loss via these routes, but relative to losses by other routes, losses via percutaneous and visceral routes is quite insignificant. Now, normally when we talk about inhaled anesthetics, we talk about the 4-compartment model, where the 4 compartments are alveoli, the vessel-rich group, the muscle group, and the fat group. Now, what is the 5th compartment in inhaled anesthetic distribution? So currently, an additional compartment has been added. This is the adipose tissue, which is present adjacent to the lean tissue. And this adipose tissue receives anesthetic directly from the lean tissue by intertissue diffusion. So this is referred to as the 5th compartment. And this transfer of anesthetic is not insignificant because this can account for up to 1/3 of uptake during long administration of anesthetics. So to conclude my talk, there are 6 steps in the transfer of anesthetic from machine to brain and back. Soluble anesthetics, which have a higher blood gas partition coefficient, have a slow induction and slow recovery because the alveolar partial pressure is slow to change. Inhalational induction can be hastened by using nitrous oxide because of the second gas effect and by using the overpressure effect. Recovery mainly depends upon the solubility of the agent, the dose and duration of administration. Hyperventilation will hasten induction and recovery, but recovery, you have to remember that you should not be causing hypocapnia. Thank you very much.
Thank you, madam, for a wonderful presentation. And the questions you have posted in the end of your presentations clarified most of the doubts, I think. Madam, can we go for that chat box questions?
Yes, sir. Sure.
Only a few questions are there. That means they understood what you have taught for the past 45 minutes. The first question is, so what is the Fink effect that you are a diffusion hypoxia?
So Fink effect is also called as third gas effect or diffusion hypoxia. As I had explained, it is because of the difference in solubility between nitrous oxide and nitrogen. So normally at the end of a nitrous oxide anesthetic, when we shut off the nitrous oxide and if you're administering air, there is nitrogen in this air. So there's nitrogen in the alveoli. Because of the reversal of this gradient of partial pressure of nitrous oxide will leave the blood, the tissues to blood and blood to alveoli much more quicker than the nitrogen which is there in the alveolar air entering. So there's more nitrous oxide in the alveoli entering compared to the nitrogen which is leaving the alveoli into the blood. As a result of this, the partial pressure of oxygen comes down in the alveoli. So this can be prevented if we don't administer air containing nitrogen. If we give 100% oxygen, this will not happen. So this is diffusion hypoxia, and it's also called as third gas effect or Fink effect.
Yes, thank you, madam. Still, they have the doubt about the difference between the second gas effect and the concentration effect.
So concentration effect applies to inhalational agents which we give in high concentration. It usually applies only to nitrous oxide and to some extent to xenon. So what happens is whenever we administer, say for example, nitrous oxide, 70% nitrous oxide, in the first minute of administration, there is a rapid uptake. Almost 1000 ml of nitrous oxide is removed from the alveoli in the first minute. Now, because this is removed and this is replaced by nitrogen, which is coming into the alveoli. Now, because more nitrous oxide is removed, the alveolar volume decreases. So whatever leftover gases are there are concentrated in a smaller volume of the alveolus. So the concentration of oxygen and nitrous oxide is going to go up now. Now, this decrease in the volume is going to cause augmentation of alveolar ventilation, bringing in more nitrous oxide. And that also increases the amount of nitrous oxide in the alveolus. So the concentrating effect refers to a rapid rise in the alveolar levels of a particular inhaled anesthetic because we are giving a larger amount, a larger inspired concentration causes a rapid rise in the alveolar concentration because of decrease in the alveolar volume size, which is a concentrating effect, and augmentation of alveolar ventilation. So that is a concentrating effect. That is nitrous oxide affecting its own concentration. Now, if nitrous oxide is going to affect the concentration of a concurrently administered another vapor like halothane or sevoflurane, by the same mechanism, the concentration of sevoflurane or halothane goes up because of rapid removal of nitrous oxide and a smaller alveolus and augmentation of alveolar ventilation. So this effect on sevoflurane or on halothane by nitrous oxide is called the second gas effect. And because it is going to rapidly increase the alveolar concentration, it hastens induction. So that's why administering nitrous oxide with these inhalational agents actually hastens the speed of inhalational induction.
Yes, madam. You have well explained this in your presentation by pictures. So the other question is a first year question. It is a common doubt in first years. If the gas is more soluble to blood, it will be higher concentration reaches to CNS. So it should be a faster induction. But higher soluble gases, slower induction. Why?
So that's a very nice question. As I explained, the most important thing to understand as far as inhalational anesthetic distribution and uptake is concerned is there's something called partial pressure and there's something called concentration. Now, equilibration across the alveoli to arterial blood to brain takes place in terms of partial pressure, and anesthesia is induced when a particular partial pressure is reached in the brain. So when we say patient is anesthetized, a particular brain partial pressure is reached. But although all these partial pressures are equilibrated, the concentration is going to be different depending upon the solubility. So the partial pressures are all same, but the concentration is going to be different in the alveolus, in the blood, and in the brain, depending upon how soluble this particular agent is in the blood and in the brain. So for more soluble agents, what happens is it is going to dissolve in the blood. So more and more is being removed from the alveoli to dissolve in the blood. So the alveolar partial pressure doesn't rise. So the very first step is the alveolar partial pressure has to rise. Only then it can equilibrate with the arterial partial pressure. Only then that can equilibrate with the brain partial pressure. If constantly by removal, this partial pressure doesn't come, we are not able to reach this partial pressure, which is necessary for the anesthetic state. So it's, if you will understand it, if you understand that there is a difference between partial pressure and concentration, and we are trying to equilibrate partial pressures, we are not trying to equilibrate concentrations. I mean, equilibration concentration doesn't happen. It only equilibrates in terms of partial pressure. I hope that answers the question.
Yes. The partial pressure of the alveolar pressure indirectly reflects the partial pressure of the brain. So the target organ. Okay, madam. The last question is surface area to volume ratio for air bubbles. Please explain, ma'am.
So when we have a smaller air bubble, the surface area to volume is more. So what happens is that the nitrous oxide is, you have say multiple small bubbles. Nitrous oxide is able to diffuse into each of these bubbles much more rather than having one large bubble, because the surface area is not much. So smaller air bubbles, the faster entry of nitrous oxide happens. So we will assume that when there's a large air bolus and you give nitrous oxide, it is going to expand rapidly. No, it's only when the smaller multiple air bubbles are there, they tend to expand much faster with nitrous oxide compared to one single large air bubble.
Thank you, madam. Okay, sir, do you want to add anything, sir, regarding the discussion?
No, just about the smaller and smaller air bubbles. You just think them as a container. So if you have a smaller container and a larger amount of gas coming in, it is likely to expand faster than a larger container which already has enough volume. So for it to expand further, it will require a lot of nitrous oxide to come inside, and then it may expand to an extent. I mean, just to make it simple.
Thank you, sir. So still they are putting questions in the chat box. So we will, in right to left shunt, right-sided cardiac output is reduced to pulmonary circulation. Does it increase the induction speed of counter dilution effect? So it we already discussed, madam.
So in a right to left shunt, what happens is the blood which is on the right side of the heart has not gone into the pulmonary circulation. So this blood does not have any anesthetic. This is moving to the left heart and moving to the aorta. So whatever anesthetic was there in the left heart is now getting diluted by this blood which does not have anesthetic. So the arterial blood anesthetic concentration will be low. So inhalational induction will be slow in right to left shunts.
To finish our discussion, before we finish our discussion, it's my own doubt, madam. In case of circulatory shock, the induction will be slower or faster, because in circulatory shock there will be intense vasoconstriction to maintain the cerebral circulation. Suppose the cerebral circulation is maintained, will the induction will be slower or not?
So the main thing what happens is, because there is a decreased cardiac output, uptake decreases now. Because uptake decreases, the alveolar partial pressure is going to reach the inspired or delivered partial pressure very, very quickly. So the upstream partial pressure rises very fast. So because the uptake is less, the alveolar partial pressure is now high. Now from this alveoli, it has to be taken to the artery as well as to the vessel-rich group. Although there is intense vasoconstriction in shock, we find that the vasoconstriction is all to the peripheral organs. It tries to maintain perfusion to the vital organs. So actually speaking, the delivery of the inhaled anesthetic to the brain is going to be much more, because at all cost, vital organ perfusion is maintained by vasoconstriction of all the other peripheral organs. So because of that reason, because of this rapid rise in alveolar partial pressure and distribution of most of this cardiac output to the vital organ like brain, that is the reason why they are more susceptible to cardiac depression, overdose with inhaled anesthetic.
I understood. So it is not related to the circulation to the brain. It is the partial pressure rise or fall in the alveolar concentration. Okay, thank you, madam. Before ending, I compliment you with the Dr. Brema Rajagobal's comment. That is nobody can make this dry topic this interesting. With that, we will conclude, madam.
Thank you. Thank you so much, sir. It was my honor to participate.
Thank you so much. Next, we will move on to the next topic. That is the understanding of the pressure. We are having Pankaj Kundra sir among us. I like to introduce him. He is the Dean Academic of JIPMER Pondicherry. He is the present President of All India Difficult Airway Association. His academic research work is excellent. I always admire his academic work. It is beyond comparison because he has made 150 publications with around 2,000 citations. So the overall research work is assessed by many parameters. There is H index and I-10 index. The H index is the metric evaluation by comparing the publications to the citations. So H index of 20 is good, 40 is outstanding, and 60 is truly exceptional. The Nobel Prize winners in physics, for example, they used to have a H index of at least 30. Our Pankaj sir has a H index of 28, which is comparable to Nobel Prize winners. Hats off to you, sir. So the H index is usually used for promotion purposes. For assistant professor promotion, they must have a 3 to 5. An associate professor, they must have 8 to 12. And associate, that is professors, they should have 15 to 20 H index. Regarding the I index, it is created by the Google Scholar to compare the author's rank. It is a number of publication of the researchers has written that have at least 10 citations. So Pankaj Kundra has I-10 index of 58. That's why I have said the research of Pankaj Kundra sir is excellent and beyond comparison. The specialty of his lecture is he used to explain the difficult subject in a simple manner to understand. Whenever I feel any topic is difficult to understand, I used to search for his lectures or papers written by Pankaj Kundra sir. So I am today eagerly waiting to listen his topic with my pen and notepad. Over to you, sir.
Thank you, Dr. Edward, and thank you all who have spared their valuable time during this Sunday weekend, Sunday morning to be present here. Thank you for those kind words, Dr. Edward. But to be frank, I have never looked at my research capacities. We just keep on doing the work, and fine if it is getting recognized. I'm today happy to hear that, because I really never looked at them, and I was not aware about the metrics which were used. Yes, we do talk about HI, H1 and other indices, but anyway, never had the time to look at them. So the topic which Dr. Edward has assigned me is about understanding vaporizers. I thought the limited time which we have, we will focus on the physical principles. If you know the physical principles, it is easy to understand how vaporizers act. Now, whenever we fill up a vaporizer, remember all of them are dispensed in liquid form, and the liquid from the bottles, you pour it into the vaporizer, and it's the vaporizer who converts this liquid into a vapor form to be delivered to the lungs and then subsequently to produce an anesthetic effect. So as Dr. Aruna has already pointed out, that you set the dial settings of volume %, but the effect is seen as a partial pressure of the gas. Remember, volume or concentrations are generally used for IV agents or intravenous anesthetic agents. They move across concentration gradient. But gases move across partial pressure gradient, and that is how they exert their effect. One of the questions was that if the gas is getting more soluble in blood, why doesn't it have a better anesthetic effect on the brain? Remember, when it is soluble, it is wasted because it has got dissolved in blood, and it is not going to be exerting the effect because it is in those forms of vapors which have turned into liquid now. And because they have turned into a liquid form, they cannot exert a partial pressure effect onto the tissues where you need them to produce the anesthetic effect. So that's the reason the partial pressure of the vapors or the gases would determine how the anesthetic effect is produced. The problem is we deliver them in volume %, but the action actually is by partial pressures. So what is volume %? The basic definition is the amount of gas in relation to 100 units of volume of a total gas mixture. So it's partial pressure of the gas divided by the total pressure into 100 will give you the volume percentage. But if you want to know the partial pressure, then the equation is otherwise, where volume % into total pressure would give you what is the partial pressure of the gas. And this is what will happen if you set 2.1% concentration on the dial for sevoflurane and the ambient pressure is 760, then the partial pressure exerted by 2.1% of sevoflurane is going to be 15.96 millimeters of mercury. All of us know that the minimum anesthetic concentration is generally talked about the amount of inhalational agent which is present and they generally talk about volume percent of the alveolar concentration of that agent. But if you actually want to know what is MAC, because that is what is exerting the anesthetic effect, then it has to be Pmac1, which means the minimal alveolar partial pressure of the gas, which is expressed as MAC in partial pressure, which becomes Pmac1, that is responsible for producing anesthesia in 50% of the individuals at 1 MAC. So MAC for desflurane is about 6. Pmac for desflurane, there will be 6 divided by 100 into 760. It will be 45.6 millimeters of mercury. Now, what happens at the high altitude? Let's compare sea level and at 10,000 feet. At sea level, the barometric pressure is about 760. At about 10,000 feet, it is about 500. If you give 1% of halothane, the partial pressure which it is going to produce is about 7.6 millimeters of mercury. But if you give 2% at 10,000 feet, then it exerts a partial pressure of 10 millimeters of mercury only. Hence, despite a two-fold increase in the volume percent, the increase in partial pressure is just 1.3 times. So the effect of the inhalational agent may not be that significant when you change the altitudes. Now, how do you convert liquid into vapor? What's the process which takes place? How do we achieve this? Which principles or physical principles are involved? Normally, whenever you leave a liquid like this, you will find that some of the molecules, by means of evaporation, have enough energy to leave the liquid surface and go into the atmosphere. And this is because there is latent heat of vaporization, which all the liquids have, and they derive energy from that, and the molecules will slowly leave. And you will find, even if you have a glass of water, and if you keep it around there, the amount of level would decrease because some of the vapors have actually left the liquid surface and evaporated. Now, when we close this container, all these vapors which were going into the atmosphere would be contained in a space above the liquid surface. And therefore, when they are contained in a compartment, they start exerting pressure. And that pressure which is now exerted by the vapors which are constantly leaving the liquid surface would be defined as the vapor pressure. However, the difference between vapor pressure and saturated vapor pressure would be that the number of molecules which are leaving the liquid pressure is equal to the number of molecules which are now returning back to form into the liquid form. That means that an end stage of vaporization has achieved. There is an equilibrium between the vapors which can now be evaporated versus the ones which return back to a liquid phase, and that will be called as the saturated vapor pressure at that particular temperature. So there is a dynamic equilibrium which has now been achieved in between the two molecules which are returning to the liquid phase and those are evaporating. And this is what is saturated vapor pressure. And this would be constant at a particular temperature. Now, what is the difference between saturated vapor pressure and boiling point? Now, let's take this container. This container is not covered. However, we have put the container on some sort of a flame, and there is an atmospheric pressure which has been exerted on the liquid surface. So what happens is these vapors, which would normally try to leave the liquid, are not able to leave the liquid surface because of the atmospheric pressure exerted on top of the liquid. But as soon as this pressure of the liquid or of the gas goes to saturated vapor pressure, that means it equals the atmospheric pressure, they will be able to overcome the atmospheric pressure and leave the liquid surface, and that is what is defined as a boiling point. So boiling point is above the saturated vapor pressure because at that particular temperature, at that particular pressure, these molecules which were trying to escape the liquid surface now possess enough energy or enough pressure to overcome the atmospheric pressure and leave the liquid. So that is what is boiling point. The importance is that at low barometric pressures, let us say at a high altitude, there will be low boiling point. Or there are certain anesthetic agents which have low boiling point, just like your desflurane. So if you want to increase the boiling point of desflurane, you will need to increase the pressure. That's the reason when we put the desflurane into a vaporizer, it is kept at 2 atmospheres so that the boiling point of the desflurane is higher than what it is dispensed at. Now, what is the purpose of a vaporizer? One is that it tries to deliver an anesthetic vapor at an accurate concentration, and this concentration should be adjustable. And all these two characteristics are achieved by the saturated vapor pressure. So the concentration of the anesthetic vapor in a gas would be constant at saturated vapor pressure. So as I told you in the first equation, the gas concentration would be vapor pressure divided by the ambient pressure into 100, or you can say that at 20 degrees centigrade, concentration of gas in isoflurane vaporizing chamber, how much would it be? So if the saturated vapor pressure is 239, ambient pressure is 760, then the concentration of isoflurane would be 31% at 20 degrees centigrade. So if this is the amount of concentration of isoflurane which can be achieved, can you deliver this concentration to the patient? Normally we do not exceed 2.5-3%, but for this 31% of isoflurane concentration which is being achieved, we need a vaporizer. And how do we achieve this therapeutic concentrations and not deliver 31% to the patient? Is by two mechanisms. You have a carrier glass, you add some carrier gas where this 30% or 31% is diluted, or you have something which can control the concentration to therapeutic concentrations which can be delivered to the patient to produce anesthesia. How are these achieved? The concentration calibration or the carrier gas flow can go through a variable bypass vaporizer where there is a splitting ratio, which means that the amount of gas which is entering into the vaporizing chamber versus the amount of gas which is bypassing the vaporizing chamber, there is a ratio which is determined at the very end when you adjust the dial concentration. And the second way is by measured flow vaporizers where vapors are added directly to the fresh gas flow. So you have a flow control knob through which you can add the vapors directly to the fresh gas flow. So either you have a variable bypass vaporizer or you can have a measured flow vaporizers. These are the two types of carrier gases which can be adjusted. Let's come to the first one first to decide what is the splitting ratio. So as I told you, splitting ratio would be the ratio of bypass gas which is going into the vapor, which is bypassing the vaporization chamber, which is bypassing the vaporizing chamber to the gas which is going into the vaporizing chamber. So if you set a dial setting of 1%, that means 46 parts of it is bypassing the vaporizing chamber and only one part of it is going into the vaporizing chamber. For isoflurane, it is 44.1 and for sevoflurane, it is 25:1. Which means that if there is a fresh gas flow of about 4.7 liters, 4.6 liters would bypass and only 100 ml of the gas would be directed through the vaporizing chamber, which gives you the splitting ratio at 1%. What about dial settings at 2%? So at dial settings of 2%, the ratios will change. so that the bypass flow would now be 22 parts, while the vaporizing chamber flow will still remain at 1 part. So that is what it means, that the bypass flow is constantly adjusted by the concentration which you have set on the dial settings. But what about the amount of gas which is going into the vaporizing chamber would generally remain the same. So your dial settings would only alter how much of the bypass flow you are regulating, whether you're decreasing the bypass flow or you are increasing the bypass flow. The second thing which you need to remember, because these splitting ratios for halothane and sevoflurane are different, you cannot use the same anesthetic same anesthetic into a different vaporizer. So the vaporizers are agent specific, because according to their saturated vapor pressures, the splitting ratios are defined. For isoflurane and halothane, the splitting ratios are almost the same because their saturated vapor pressures are quite similar. But you cannot use the same vaporizer for sevoflurane, because otherwise you will be giving or delivering a very high concentration. So when you talk about the vaporizer output, we have already discussed it's the barometric pressure which can determine how much of vaporizer output it is going to produce. So if you have a low boiling point, you will have to increase the vapor output, and therefore that's how desflurane is dispensed and kept into a vaporizing chamber where the atmospheric pressure is where it is at 2 atmospheres. If the boiling point of a liquid or a low atmospheric pressure is there, then the boiling point is reduced, and the carrier gas flow is generally governed by the splitting ratios. Now let us talk about the other 3 factors which can determine the vaporizer output. The fourth one is the surface area of vaporization. So there is something called as plenum type. Plenum means increasing the internal resistance, thereby increasing the pressure. So the plenum type of vaporizers are seen with variable bypass vaporizers, which can be either low resistance or plenum type. In plenum type, the internal resistance is high. In low resistance, the internal resistance is low. In plenum type of variable bypass vaporizers, the fresh gas flow is above the atmospheric pressure, whereas in low resistance, the fresh gas flow is at atmospheric pressure, because the fresh gas flow is driven by the patient's respiratory efforts. So you will get accurate fresh gas flows and agent concentrations will be accurate if the fresh gas flow is between 0.25 to 15 liters per minute in plenum types, but in low resistant type of variable bypass vaporizers, the agent concentration is likely to be highly inaccurate at low and high fresh gas flows. How does this happen? If this is a low resistance flow over type of vaporizer, as you see, it is open to the atmosphere and it depends upon the patient's efforts. So this is the fresh gas flow which passes through the liquid over the liquid surface and carries the molecules or the vapors along with it to the other port where the patient is trying to inspire. So what will happen? If it is at a low resistance and if you increase the fresh gas flow, the flow will increase, but the liquid surface contact with the flow remains the same. So the entire fresh gas flow cannot achieve full saturation, and the amount of vapors which would be inhaled by the patient would be much less as compared to a lower flow rates. So that is where the agent concentration can actually be compromised once the fresh gas flows are altered whenever you have low resistance type of variable bypass vaporizers. Now, what do we need? Looking at the example here in the low resistance, we need to know that we can, if there is some mechanism that we can maximize the surface area of vaporization, then probably we can match the agent concentration to the increase in fresh gas flow. And this is generally achieved by putting Teflon wicks whereby the liquid agent can spread over a wider area through capillary action, and therefore it can increase the area of vaporizations. Some of the vaporizers also use metal baffles so that the incoming gas is directed to the vaporization chamber via channels created by a metal baffles, therefore enabling that when you give a higher fresh gas flow, there is complete saturation. How is it achieved? We will come to know by this simple diagram. So this is a vaporizer which has the inlet. So this is the fresh gas flow which is going to come. This is the bypass area, or the gases are going to be bypassed from here, and some of them are going to be directed into the vaporizing chamber. So what have they done is that the inlet, this is the outlet, this is the inlet to the vaporizing chamber. The inlet is made into a convoluted form. Like you see the queues in the temples, you go through various, they create baffles so that they can accommodate larger number of people inside the temple, but you keep going across those convolutions before you can reach the deity. Similarly here, the gas will have to travel through these convolutions, and all these convolutions would have the wicks. This wick is just dipped here into the vaporizing chamber. So through capillary action, this wicks would be drenched with the anesthetic liquid. So as the gas is moving across, it starts coming in contact with the vapors in the wick, and it starts getting saturated. By the time it reaches the liquid surface, it is almost saturated. And when it comes here, whatever is not saturated would again get saturated, because they have created another baffle at the exit, and therefore slows down the fresh gas flow so that it has time to get saturated before it leaves the vaporizing chamber and joins the bypass gas flow to give you the desired concentration. So that is how a plenum type of mechanism is created, because you create convolutions. There is stagnation of fresh gas flow here. There is a pressure which is built up. And because of all these, the fresh gas flow now gets fully saturated, even at high flows when you give it, when you give it to the patient. So this is what will happen. This is the bypass flow. The amount of gas which is going into the vaporizing chamber goes through a convoluted passage. It gets saturated fully before it joins the bypass gas flow, and then it is delivered to the patient. Now the other part is the temperature of the liquid comes down because it starts losing vapor, and as the latent heat of vaporization is used, or the more of the liquid is transformed into the vapor form, the temperature of the liquid comes down. And once the temperature comes down, the vaporization of the from the liquid also decreases. So how does the vaporizer try to overcome this kind of a problem? And the second part is gas liquid interface. We'll come to the second example to tell you both these mechanisms, how these vapor outputs can be altered. So this is an ether bottle which we used to use when we used ether. And when we used ether, the most important factor which will decrease the vaporization would be that the ether cools down very fast, and you will find that the bottle is covered by a frost as the vapors are increased, and you will find a frost there, and you will have to keep wiping off that frost, try to keep warm the temperature of that ether bottle so that the anesthetic depth is not compromised. Now, what are the components of this ether bottle? It has a control knob which is depicted here, and I am putting it here on this animation. It has a plunger here. So this plunger is attached to a kowloon or a hood. Okay. So once you depress the plunger, the kowloon comes down and down and down. Right. So it will depress the kowloon over the exit part of the gases which are going through the ether bottle. Now let's see how it creates an effect. So this is a Boyle's bottle which you used to have. So the bypass gas goes through here. But if you look at the gas which is directed into the vaporizing chamber, it doesn't allow the gas to leave the tube at the liquid level. The point of exit of the gases is above the ether level. This is the mark which has been put here. So when you put the ether till this mark, this Kowloon will be above, and the gases coming into the vaporizing chamber would exit from this place. So when they try to exit, they meet an obstruction or a chimney kind of or a hood kind of a thing, and by this hood they are directed over to the liquid surface, and then they collect, and then the gas collects the vapors from the liquid surface and then comes out through this outlet to join the bypass fresh gas flow. So this is how it works. So even when the knob is fully turned down, the Kowloon is still above the liquid surface. Now, when you want to hasten induction, what we normally used to do was, we used to use this plunger. As soon as we depress the plunger, the Kowloon goes below the liquid level or the anesthetic liquid level. Therefore, whenever the gases come out, they will leave they will come out from here, but when they come out, they will come out through the liquid. Therefore, bubble the liquid out, and they will get, and that vaporizing gas would get saturated with the vapor pressures of ether, and then it would leave the exit part to join the bypass fresh gas flow. So this plunger was used to make the ether bottle a bubble through vaporizer, wherein the Kowloon dips below the ether level, and therefore it directs the fresh gas flow coming into the vaporization chamber into the liquid to produce bubbles to collect more of anesthetic vapor before it leaves the vaporizing chamber and joins the bypass fresh gas flow. The problem here was, it was not temperature compensated, but it was flow over as well as bubble through vaporizer, which can be used. But at the same time, the similar kind of bottle which had different capacities could be used for trilene, where the bottle was smaller in nature, and it could also be used for chloroform. So the vapor output, depending upon the gas liquid interface, can be a draw-over vaporizer or a bubble through vaporizer, depending upon how the anesthetist is going to use it and the type of vaporizer he has. Now we talked about the temperature of the liquid which comes down as the vaporization happens. So this cooling decreases the vapor output. How do we manage? This can be managed by two mechanisms. One is by temperature stabilization, the other is by thermal compensation. The temperature stabilization is achieved by constructing the vaporizer by material which has high specific heat, so that they can store much more of heat. So whenever the vaporization occurs, this metal can supply heat for vaporization to be compensated, and high thermal conductivity, so that the heat transfer from the metal to the liquid is faster. The second one is by thermal compensation, where bimetallic strips and aneroid bellows are used. So thermal compensation, when we talk about constant which will produce constant vaporizer output despite changing in temperature, is generally achieved by bimetallic strip. What does it do? It alters the splitting ratio. It can also be computer controlled in electronic vaporizers, or it can be by means of supplied heat, which is seen in Tech 6 or desflurane vaporizers. How does it alter the splitting ratios? So this is the thermal compensation you can look at. High temperature and low temperature, these are two metals with high different coefficients of thermal expansions which are fixed together. So when the temperature is low, the metal which still has a high thermal coefficient would still expand, but this one will not expand, therefore it moves to the right, and it will be the other way with the high temperatures. So when these two metals are bound together, this is the inlet to the vaporizer. So it is a normal position, the normal splitting ratio is maintained, but when there is a fall in temperature, the temperature coefficient of one of the metal drops down, the other still remains, and the input or the inlet to the vaporizing chamber is widened so that more of the vaporizing gas equivalent to the amount of liquid which is being vaporized is passed. So this opening would actually be proportional to the amount of vaporization occurring within the vaporizing chamber. And that is how temperature compensation would be provided for the fall in temperature because of vaporization. So next in line were the tech vaporizers. The tech vaporizers were basically variable bypass where concentrations were calibrated like we have discussed earlier. Temperature compensation is provided by bimetallic strips, and they are all plenum type. That means there is high internal resistance and they're all agent specific. In Tech 3, there was a problem of back pressure compensation. In Tech 4, they introduced interlock mechanism, they introduced internal baffled, and to make sure that wrong agents are not filled up into the wrong vaporizers, they used keyed filling adapters and bottles. And in Tech 5, they produced an IPPB assembly so that there is a constant vapor output. And Tech 6 is the injection type or the electronically controlled. So this is in short the classification of tech vaporizers. The hazards are that in Tech 2, basically there were two mechanisms which are seen. One was a pressurizing effect, the other was a pumping effect. Now, if you look at the output of the vapor versus the dial setting and the flow rates, you'll find that at higher flow rates of about 5 liters per minute, whatever is the dial setting, it is perfectly okay. It is you are achieving the dial setting which you are setting and the vaporizer is delivering that much. But as the flow fell down below 5 liters or 4 liters, the dial setting here is 4, but the output has gone to 7.5%. The dial setting here is 3%, and when you deliver it at 2% or flow rates of 2 liters per minute, actually you are almost delivering 3.5%. And at times with lower dial settings, you will be not achieving the same concentration. Your output will be much lower than what you have set when you go to lower flow gas flows. So these were the problems which are occurring with the Tech 2 vaporizers, and they predominantly happened because of pressurizing and pumping effect. Now, what is a pressurizing effect, and what have the manufacturers done? In normal conditions, there are two valves here. This is the back check flow valve, and at low fresh gas flows, whatever is coming into the vaporizing chamber and whatever is going out is perfectly fine. There are no issues. But as soon as you increase the flow rate, you'll find that because of resistors which are put here and here, the amount of gas which is coming out is much less because the flow of the gas is much higher, and this opening, this check valve is limiting the flow from coming out. Therefore, there is pressure which is built up, and once the back pressure builds up, that pressure is transmitted into the vaporizing chamber. These molecules of gases which were not saturated with the vapors will now get saturated, and you will be delivering a higher concentration with what you have set. So there is compression of the gas, that therefore more millimoles per ml is delivered than what you set, and the anesthetic vapor, as I told you, will always remain constant because it is temperature compensated. The SVP is the same. Because there is a pressure buildup at the vaporizer outlet, you'll find that you end up delivering more concentration than what you have set at the dial. So the net effect would be decreased anesthetic concentration which is delivered, because from here whatever is happening is coming there. Now what about the pumping effect? The pumping effect is that reservoir bag fills up with expired gas flow and the fresh gas flow. So during expiration, whenever you have already squeezed the bag, during expiration, the reservoir gas is going to be filled up because of the fresh gas flow which is coming up and the expired gas flow which is coming from the patient into the reservoir gap. So next time when you squeeze the reservoir bag, what will happen is, because of this squeezing effect, the pressure, a back pressure is produced, and this carrier gas is squeezed back into the vaporizing chamber and into the bypass chamber. And therefore, the net effect would be that a higher concentration of gas would be delivered when you release the bag, when you next time squeeze the bag, as when you have done earlier. So this mechanism was prevented by having a check flow valve which was created here, so that whenever positive pressure ventilation was done, there is no back pressure effect which is created to the vaporizing chambers. Now let's come to the measured flow vaporizers. These are all variable bypass vaporizers. As I told you earlier, when we talk about measured flow vaporizers, it means there are two flow control knobs. The gas which is going to go across the bypass chamber is controlled by one flow control knob, and the amount of fresh gas flow which is going into the vaporizing chamber is governed by a second flow control knob. Therefore, whenever you open these two control knobs, this flow will determine how much, whatever you open up will determine how much of the gas is being directed into the vaporizing chamber and would join the bypass gas flow here to give you the desired effect. And you can see the liquid indicator here and see how much of the level it is. So by this mechanism, you can have a single vaporizers, but you can use multiple agents through this. So the copper kettle principles which are applied here is that there are separate flow meters for the vaporizing chamber and for the bypassing chamber. The desired concentration of the agent is calculated either by a circular slide rule, where the saturated vapor pressure of the agent at indicated temperature is given, and the rates of two fresh gases flow rates which you are adjusting here are also given. And then you would know what concentration of the agent you are giving. Now, if you have to calculate manually how it is achieved, how this circular slide rule was calculated, let us consider this equation. To achieve 1% concentration of isoflurane at 20 degrees, you will require a vaporizer output which will be equal to the vaporizing chamber inflow of fresh gas flow into saturated vapor pressure of isoflurane divided by the barometric pressure minus the saturated pressure of isoflurane. So if you are directing 100 ml into the vaporizing chamber, the SVP for isoflurane is 239, and the difference between barometric pressure and the SVP of isoflurane is 760 minus 239. You will find that your 100 ml is getting saturated with 46 ml of isoflurane, which is going through the vaporizing chamber. So the total amount of fresh gas flow which is coming out of the vaporizing chamber would be the 100 ml initially which you have set, plus the 46 ml of vapor which is being collected by this 100 ml. So the total amount of fresh gas flow will be 146 ml now. If the bypass flow or the fresh gas flow which is bypassing, which you have set at 4.5 liters, then the total fresh gas flow would be bypass flow of 4.5 liters plus 146 ml, which is coming through the vaporizing chamber. So the total fresh gas flow is 4.6 liters. And if you want to calculate the amount of sieve of isoflurane in this 4.646 of liters of fresh gas flow, 46 ml only has been added. And if you look at this equation, you will get 1% of isoflurane. So that is how, according to the fresh gas flows with this copper kettle principle, you can calculate what is the percentage of inhalational agent which is being added by means of your flow regulator into the bypass flow, and you get and what is the concentration in the total fresh gas flow. So this is how you normally do it. The step one in this setting would be you first set the concentration desired in the total fresh gas flow. The second will be match the temperature of the selected agent and fresh gas flow through vaporizer. Now let's come to the last part of modern electronic vaporizers, which most of you would be using it. For example, the Tech 6 or the Tech 6 Plus vaporizer, which is concentration calibrated because it is injection type. It has got thermocompensation because of supplied heat, and it is agent specific only for desflurane, and it is plenum type. Now look at the vapor pressure, the change in vapor pressure with the change in temperature. With a small change in temperature, the amount of change in vapor pressure is quite high. And if this occurs, then if this curve is so steep, what is this temperature curve? Then for the bimetallic strips, which will try to compensate for the temperature changes, is not going to happen. So the bimetallic strip cannot do the justice to the change in temperatures which happen because of the low boiling point of desflurane. Therefore, we need something better. We need precisely controlled temperature mechanism which is not affected by room temperature. So this is how the desflurane tech vaporizer will function. You have a fresh gas flow which you will give to the patient. As we discussed, because the boiling point is low, the desflurane is kept at 2 atmospheric pressures to increase its boiling point. You have a dial or a flow control knob which is integrated with this circuit or this flow control knob for the circuit here, right? So this is integrated with the dial as such. Now, whenever you deliver some amount of gas flow, the fresh gas flow would come here, will be delivered into this area. At the same time, some of the fresh gas flow would be diverted into this circuit, where according to the dial settings, that much amount of gas would be allowed to go into the vaporizing chamber. So this is the dial concentration which you are setting on the sevoflurane vaporizer. On the other hand, there is one knob which is actually making this, increasing the resistance of this tubing to whatever flows which you are setting here. So these two are actually integrated. The moment you decrease the dial setting, the circuit resistance is increased so that less amount of fresh gas flows is allowed to pass into this chamber, right? So that is how it works. But now once you increase the fresh gas flow, then this circuit resistance which is happening here is not altered because you have not changed the dial flow at all. But the amount of gas which is added to the fresh gas, or the vapors which are added to the fresh gas flow, would be the same. So your concentration of desflurane will come down. So what they have done is, they have attached a transducer here. Therefore, as soon as you increase the fresh gas flow, this diaphragm is lifted up because of increased pressure which is built up on this side. And for the person to detect, or for this machine to detect that there is increased pressure, what they have done is, they have done is they have integrated it to a transducing mechanism whereby the differential pressure transducer will detect that there is an increase in pressure here. It will decrease the resistance accordingly, and therefore allow more of the fresh gas flow to go in and collect more vapors to match the increase in fresh gas flow which has been done by the operator. So this is how the pressure regulation is done by differential fresh gas flows at low and high temperature by electronic systems. Lastly, coming to the Aladdin cassette, these are magnetically coded. It behaves like a variable bypass and a measured flow vaporizer. So you have magnetically coded vaporizers as such. It has got automatic agent identification. How does it work? There is a throttle valve mechanism from the anesthesia CPU. The fresh gas flow will go through this bypass chamber as well as through this vaporizing chamber. Whatever flow is directed into the vaporizing chamber will collect the vapors, and then it will join the fresh gas flow. There are two resistors which are put at both ends for the bypass flow as well as the output of the vaporizing chamber from the vaporizing gases which are coming out. So there are flow sensors which are kept here where the pressure drop is proportional to the gas over this fixed resistance. Now, you need to have certain pressure monitors as well here to determine what is the pressure drop which is occurring because of this resistance which is happening here. So whenever there is a fresh gas, the pressure which is higher in the vaporizing chamber, then than at the outlet, then what the vaporizer will do is it will shut off the gases which are going to go into the vaporizing chamber till this pressure equalizes or becomes more than the vaporizing chamber. But how does this vaporizing chamber come back to its normal if it is high? So there is one cassette relief pressure valve which is provided, which can help to release the pressure from the vaporizer, right? So this is a pressure relief which can occur here. So there always has to be a pressure which is at a higher point than the pressure, than the vaporizing chamber, for the gases to come out from the vaporizing chamber and join here. The other mechanism which is, so whenever the pressure falls below the common outlet pressure, then the gases would be resumed to go through the vaporizing chamber and join the fresh gas flow. So here the vapor concentration will be equal to the vapor pressure divided by the total pressure in the cassette. So that is how the vapor concentration is determined by these two pressure transducers which are attached into the vaporizing into the cassette Aladdin cassette vaporizer. The other thing is the agent proportionating valve, which you adjust by altering the dial flow of the agent, how much you want to release. So there is another valve which will govern how much of the the gas will have to come out from the vaporizing chamber. So one is the pressure, the other is the dial settings which will alter this agent proportionating valve. The temperature compensation here again would be proportional. Amount of temperature drop would be determined of how much of the liquid has been turned into the vapor phase. Lastly, to the injection vaporizers. Why do we need injection vaporizers? Now, the new anesthesia machines are so good that with low fresh gas flows, without wasting gases, you will still be able to get the end tidal agent concentrations. For that, we need to understand two things. The expired agent or sevoflurane, the expired sevoflurane concentration of 2% should be present in the circuit of 4 liters as well as the FRC which you have. So the total volume is about 6,000 ml which needs to be filled up. And if you have to fill up this 6,000 ml with 2% sevoflurane, then you need about 120 ml of vapor. So that's the amount of sevoflurane vapor you will require to fill up 6 liters of the dead space of the FRC and the circuit which you have. Now, if I want to achieve this 2% agent concentration or the expired agent concentration with a minimal amount of oxygen, so that the fresh gas flow is what your body needs. Let's say we need our oxygen uptake or requirement is 180 ml per minute. Normally you give fresh gas flows of 6 liters, 8 liters. Lot of agent is wasted. But if I want to make that my fresh gas flow is equal to the oxygen consumption only, and still I can achieve 2% of end tidal concentration within 1 minute, so that the induction time is 1 minute, then what do we need? You need 120 ml of sevoflurane vapor. So if you add that to 180 ml of the fresh gas flow, the total would be about 120 divided by 360. It is about 0.4. So the vapor output which will require is about 40%. So if you decrease the fresh gas flow, your vapor output has, or your dial concentrations have to go up simultaneously. But if you increase your concentrations here, then you can come down on your fresh gas flows. But here I am only using 180 ml of fresh gas flow, and I want to achieve anesthesia or 2% target in 1 minute. I will require my vaporizer to deliver sevoflurane at 40%. None of the vaporizers can deliver more than 8% of sevoflurane. So what do I need? I need some sort of an injection vaporizer which will produce a vapor. Therefore, 1 ml of isoflurane, how much amount of vapor it is going to produce? The molecular weight is about 184.5, specific gravity is 1.5 gram per cc. So according to Avogadro's hypothesis, if 184.5 grams per moles of isoflurane occupy 22.4 liters at STP, 1 gram will generally require, if you use this equation, 194 ml of vapor. And this can be achieved only by injection vaporizers, because these injection vaporizers directly inject liquid into the fresh gas flow. And by directly injecting the liquid, you can achieve that 40% of required isoflurane concentration with only 180 ml of fresh gas flow and achieve anesthetic target of anesthetizing the patient within 1 minute. So that's the beauty, that it doesn't allow any wastage of the fresh gas flow. It doesn't allow any sort of environmental pollution, and still allow you to titrate your agent concentrations rapidly in a closed system. So to summarize, remember to translate liquid into vapor, you need to know the difference in volume percentage and partial pressures. At higher altitude, the partial pressures are not too altered. Therefore, it doesn't make much difference. Liquid to vapor conversion is done by saturated vapor pressure and boiling point characteristics of the volatile agent. You need to optimize the vaporizer output, which is done by splitting ratios, the plenum mechanism, temperature stabilization and compensation. There are measured flow types of vaporizers which use multiple agents, but there is always a danger of mixing up the agent. Suppose the previous anesthesia team has left something, you do not know what it is. It basically works on the principle of copper kettle. The tech vaporizers are agent specific. The newer ones have come off with the pressurizing and the pumping effects. The modern electronic vaporizers are CPU controlled, like Aladdin and injection vaporizers. Thank you very much. It was a big topic. Whatever I could try and cover up, I have tried to do that. Thanks a lot for giving me this opportunity.
Thank you. Thank you very much for your mesmerizing presentation, sir. There are a few questions in the chat box.
Yeah, just give me time to attach the power adapter. You can just.
So after this presentation, there will be a quiz containing 10 questions. You can answer in the poll mode. please be there for the discussion to end. So next week we are having a case discussion for the sake of final year PGs. It is regarding the mitral stenosis and mitral stenosis in pregnancy.
Yes, sir.
Thank you, sir. Sir, it is the volume, percentage volume and MAC value are the same. How is it related to each other?
Percentage volume is just talking about the dial concentrations which you are setting. But normally we tend to think that minimum alveolar concentration, that is what the MAC means, right?
Yes,
it only means that it is the minimum alveolar concentration. But we know that the anesthetic effect is not achieved by concentration, but by the partial pressure of the gas. Therefore, to represent MAC into partial pressures, they have started using the terminology of Pmac1.
okay.
So that's the difference. It's just to emphasize that people don't confuse minimum alveolar concentrations to dial concentration, but should remember that it is Pmac, not the MAC.
Yes, sir. Thank you, sir. So next question is how to calculate the splitting ratio?
These splitting ratios are inbuilt by the companies. When they make or construct the vaporizers, they make sure that the splitting ratios are kept constant according to the saturated vapor pressure of the agent. Therefore, all vaporizers are agent specific. So you will have to use halothane vaporizer only for halothane, isoflurane only for isoflurane, sevoflurane only for sevoflurane. So these are manufacturer related specifications which they set the splitting ratios during the time of manufacturing the vaporizers.
Okay, sir. So why the differential transducer mechanism which is present in the desflurane vaporizer not present in the sevoflurane vaporizer?
See, it requires a lot of electronic integrations. With the normal tech vaporizers which you have, which are relatively simpler, they do not have an electrical connection or electronics involved. They are basically only pneumatically governed. But if you want to have a differential pressure transducers like you have desflurane, you need to attach a AC power output there, because that will make sure that your differential transducers work. So that's the reason in the tech type of vaporizers, to bring down the cost and still you can deliver accurate concentration, this kind of mechanism is not necessary.
Okay, sir. So the 40% of injected vapor, will it cause cardiac complications?
It will not, sir. The reason is the fresh gas flow is bare minimum. So what you are trying to do is, you are trying to fill up that 6 liters with 2% of expired concentrations of sevoflurane, saturate that as early as possible. So you are going to achieve the same 2% concentration. So the end product is, it is the 2% concentration in your FRC. That is what you are trying to achieve. Whether you use 40% at the vaporizer end or you used 8%. With 8%, you will be using 10 liters of flow. With 40%, you will be using 180 ml of fresh gas flow. So there will be no effect on the cardiac output, because your FRC is only filled with 2%. It is only the proximal to the, in the breathing, in the vaporizers, that you have made such provisions that you can achieve very rapid induction, having 2%, which can come even with very low flow rates. Now in a child or an adult, when you do an inhalational induction, you will require at least 10 minutes, 15 minutes. That is the amount of time with a fresh gas flow which will be 6 to 8 liters. And imagine how much amount of vapor is going to get wasted into the theater. Whenever we do inhalational inductions in children, half of the time we inhale it and we really feel drowsy at the end of the case. But here, the machine is allowing you to use only 180 ml, 0.18 liters per minute of oxygen only. All it is trying to do is compensate that amount of vapor into that small amount of fresh gas flow so that your FRC of 2% of sevoflurane is achieved rapidly without any wastage of the gas.
Okay, sir. Sir, another question is, how does the output of Aladdin cassettes and injection vaporizers change with altitude?
These will not actually change because they're all electronically configured, and they whenever you have these vaporizers, generally they are calibrated at the atmospheric pressure at sea levels. But when they want to take it up there, they can also calibrate these vaporizers at that particular level so that these pressure alterations do not occur. So it all depends where you calibrate your vapor pressure, your vaporizers for them not to affect your vaporizing output.
So what are the mechanisms to reduce the pressure and pumping effect?
The pressure and pumping effect are basically being reduced by your backflow check valves. In Tech 5, they have added the IPPV assembly so that the back pressure effects are kept completely out of the vaporizer system, and that is how they have managed to do it. So just a backflow check valve and the IPPV assembly, which has been incorporated, has negated these two effects which used to happen in the earlier type of tech vaporizers.
Thank you, sir. Thank you so much for sparing your valuable time, sir. Thank you so much, sir. Thank you. On behalf of postgraduates, I thank once again, sir. Thank you.
Thank you very much.
Shilpa, we can go to the next session, that is online quiz. So this is the quiz corner. We come to the quiz corner. We have 10 questions. The first question is, the minimum alveolar concentration is highest in neonates versus other age groups with which of the following? Isoflurane, sevoflurane, desflurane, nitrous oxide. That means the minimum alveolar concentration is higher in neonates. In all other inhalation agents, it is higher other than the age groups of 1 to 6 months. In 1 to 6 months, the MAC value will be higher for all inhalation agents, except one, where the inhalation agent, the MAC value is higher in neonates. So which is the inhalation agent where the MAC value is higher in neonates? That is the question. So first choice is isoflurane, sevoflurane, desflurane, nitrous oxide. You can go for the polling. This question I have already posted in my WhatsApp group. So those who are in my WhatsApp group know the answer. So most of them are answered correctly. It is a sevoflurane. We can start. So it is sevoflurane. So the MAC for inhalation agents varies with age. Most of the volatile anesthetics has highest MAC value are for the infants in the age group of 1 to 6 months. The infants younger than 1 month and older than 6 months, the MAC value is lower for isoflurane, halothane, and desflurane. But for sevoflurane, it is different. For sevoflurane, the MAC value of neonates 0 to 30 days is 3.3. For infants 1 to 6 months, it is 3.2. And for infants 6 to 12 months, it is 2.5%. So we'll go to the next question. Which of the following volatile anesthetic decreases the systemic vascular resistance? Sevoflurane, isoflurane, desflurane, or all of the above? Poll, please. Yes, most of them are answering correctly. So we'll see the answer. So it is all of the above. So all the present day volatile anesthetics reduce the blood pressure in dose dependent fashion. That is desflurane, sevoflurane, isoflurane, they cause primarily reduction in the systemic vascular resistance. But in halothane and enflurane, they produce hypotension via direct myocardial depression. So we will go to the third question. So with which of the following inhalation agents cardiac output is moderately increased? Is it halothane, sevoflurane, desflurane, isoflurane, or nitrous oxide? Poll, please. So which inhalation agent reduces the cardiac output? Sorry, increases cardiac output. So you have a doubt about this answer. So most of them, they have doubt about. So only there is 4 option is there. So they have added 4th option in the 5th option in the 4th option. Okay, we will see the answer. So halothane tends to decrease the, its answer is the nitrous oxide. So halothane tend to decrease the cardiac output, whereas sevoflurane, desflurane, isoflurane tend to maintain the cardiac output. The nitrous oxide tend to increase the cardiac output primarily because of the increase in sympathetic tone. So coming to the 4th question, which of the following parameters is most responsible for the potency of an inhalation anesthetics? Is it vapor pressure or oil gas partition coefficient or blood gas partition coefficient or brain blood partition coefficient or molecular weight? Poll please. So it is potency is determined by which character? No, you have a wrong idea. I will tell the answer. So the answer is, it is oil gas partition coefficient. So the oil gas partition coefficient determines the potency of an inhalation anesthetics. The oil gas coefficient is inversely related to the MAC value. If an agent has high potency, it will have a low MAC and a high oil gas partition coefficient. For example, methoxyflurane has a MAC value of 0.16%. It is low because it is a high potency. So inhalation agents, the order of most potent to least potent are as follows. That is, methoxyflurane is highly potent compared to the nitrous oxide, and desflurane is the least potent. They have a high MAC value, but their oil partition coefficient will be low. So coming to the 5th question, if cardiac output and alveolar ventilation are doubled. So Arna Prameswari Madam has mentioned this in her presentation. So the effect of rate of rise of FA by FI, that is rate of rise of alveolar concentration of the isoflurane compared to the which existed immediately before this intervention. That means before the increase in cardiac output and increase in alveolar ventilation. That is when the cardiac output and alveolar ventilation were normal. So compared to that previous situation, the alveolar concentration will be doubled or somewhat increased or unchanged or somewhat decreased or off. I think you understand. When the cardiac output and alveolar ventilation is doubled, whether the concentration will be increased or decreased. So that is the question. You can. So most of them are answering as unchanged. So we will see the answer. So the increase in cardiac output and increase in alveolar ventilation has an opposite direction of rate of increase of alveolar concentration. Suppose the cardiac output is increased, means more inhalation agent will be taken from the alveoli. So the rate of rise of concentration of the inhalation agent in the alveoli will be slower. It will be slow. Suppose the alveolar ventilation is increased or doubled, means more inhalation agent will be supplied to the alveoli. So the rate of rise of alveolar concentration will be high. So both the functions, that is increase in cardiac output and increase in alveolar ventilation, acts in the opposite direction. But the two opposing options do not completely offset. If you double the cardiac output and double the alveolar ventilation, they will not oppose one another equally, because increase in cardiac output means more anesthetic gas is taken from the alveoli, so alveolar concentration falls. So the increase in cardiac output at the same time deliver the inhaled anesthetic gases to the tissues. So the equilibrium between the tissues and the blood will be achieved quickly. So the venous return that comes to the alveoli will have a more inhalation agents. So the difference between the alveolar concentration and the mixus venous concentration will be narrow. So the rate of taking of the inhalation agent from alveoli reduces as the cardiac output increases. So they will not equally offset each other. So there will be a slight increase in the rate of alveolar concentration. So this is the graph. If you double the ventilation and cardiac output, there will be a slight increase in the rate of rise of alveolar concentration. So coming to the sixth question, which of the following inhalation anesthetics is most likely to produce coronary steal syndrome by preferentially dilating the small coronary arterial resistance vessels? It is a halothane, isoflurane, desflurane, sevoflurane, or nitrous oxide. Poll, please. Poll, please. Yes, you can answer. So all of you know which inhalation agent dilates the coronary vessels and produce coronary steal syndrome. It is nothing but it is isoflurane. Okay, nothing else than isoflurane. So coming to the isoflurane, it dilates the coronary vessels. But remember, the atherosclerotic vessels cannot effectively dilate. So the normal coronary vessels will be dilated more than these atherosclerotic vessels. So more blood will be diverted to the normal tissues rather than the ischemic tissues. That is called steal syndrome. Of the listed drugs, isoflurane produces the significant coronary vasodilatation. Remember, this was once thought to be the great clinical significance, but over time has been shown to be a little significance. It is of only a little significance. So question number 7. You have to follow this question very carefully. A 31-year-old moderately obese patient receiving general anesthetics for cervical spine infusion. You have to concentrate on the vaporizer setting of 2.4% of isoflurane. The nitrous oxide flow is 500 ml per minute and oxygen flow is 250 ml per minute. So the inspired isoflurane concentration is 1.7%. The expired isoflurane concentration is 0.6%. So approximately how many MAC of anesthesia would be represented by the alveolar concentration of the anesthetic gases? It is a 0.85 MAC, 1.1 MAC, or 1.8 or 2.1. The question may looks very difficult, but the purpose is to teach you what is the MAC value you have to look into when you give anesthesia. You try to answer. Don't bother about the correct answer. I will explain. So you are nearly most of them answer correctly. So I will end the poll. It is 1.1 MAC. Okay. So how to arrive this 1.1 MAC? So the two things you have to remember. First, MAC value is additive. So a fraction of the MAC, each individual gas must be added to arrive with a total MAC. Suppose you are using a nitrous oxide, you are using a inhalation agent, you have to calculate both MAC value and take as the added value as a total MAC. So that is the most important point. The second point is you have to take the end-tidal concentration rather than the inspired inhalation agent concentration. So end-tidal concentration represents the alveolar concentration, not the inspired inhalation agent concentration. So the two things you have to remember. Then you can easily calculate. Now they have kept nitrous oxide of 500 ml, 500 ml and oxygen of 250 ml. That means they are giving 63% of the nitrous oxide. That means 0.6 MAC because nitrous oxide MAC value is 104. So they have given 0.6 MAC of nitrous oxide. Now coming to the isoflurane. So the end-tidal isoflurane concentration is here they have given is 0.6. So the MAC value of isoflurane is 1.17. Now you have to calculate the delivered MAC value. So 0.6 end-tidal inhalation agent, that is isoflurane, divided by the MAC value of the isoflurane is 1.17. So it comes to 0.5. So you have to add both MAC value, that is isoflurane MAC value and the nitrous oxide MAC value. So 0.6 plus 0.5, it comes to 1.1 MAC. I hope you understand. So the 8th question is, the desflurane is administered via a heated vaporizer. Heating this volatile anesthetic allows for its accurate administration by which of the following mechanism? So Pankaj Kundra sir has answered this. I have mentioned this in his presentation. So the lowering the partial pressure of desflurane within the vaporizer, or it raises the partial pressure of desflurane within the vaporizer, or lowering the partial pressure of fresh gas flow through the desflurane sump, or raising the partial pressure of the fresh gas flow through the desflurane sump, or minimizing the creation of the bubbles within the vaporizer. By which mechanism it increases the concentration? So you can answer. Yes. So you understand what Pankaj Mitra has taken in his lecture. So most of them are correctly answered. So it is the raising the partial pressure of the desflurane within the vaporizer. So you know the desflurane has a vapor pressure of 660 mm of mercury, which is very close to the barometric pressure of 760 mm of mercury. So when desflurane is heated to 39 degrees Celsius, it will raise the partial pressure to approximately 1500 mm of mercury. That means 2 atmospheric pressure. So ensure a constant. Why the pressure is high, 2 atmospheric pressure? To avoid a fluctuation due to the change in the atmospheric pressure and temperature. That is simple. To avoid the change due to barometric pressure and temperature pressure, they have heated the desflurane to 2 atmospheric pressure. So coming to the 9th question. So a 73-year-old man with diabetes, GRD, pre-echocardiogram shows grade 2 plus mitral regurgitation. So a patient of mitral regurgitation presented for inguinal hernia repair. Which of the following anesthetic agents is most likely to precipitate worsening of the mitral regurgitation? That means which inhalation agent we should avoid in mitral regurgitation? Desflurane, halothane, isoflurane, sevoflurane, or nitrous oxide? Poll, please. Which inhalation agent you have to avoid in mitral regurgitation? So most of them have answered halothane. We will see the answer. Yes, halothane. Why? Because what is the goal of mitral regurgitation? You have to maintain the heart rate and you have to maintain the systemic vascular resistance. You should not reduce the heart rate and you should not increase the systemic vascular resistance. So that is the goal of mitral regurgitation. So halothane has a minimal effect on systemic vascular resistance. All other inhalation agents reduces the systemic vascular resistance. Halothane has minimal effect in the systemic vascular resistance. So the other volatile, so the halothane then maintains or causes a dose-dependent decrease in heart rate. So it decreases the heart rate, you maintain the systemic vascular resistance. Once the systemic vascular resistance is maintained, or maintained means the shunt will be increased. When heart rate is reduced, the diastolic time is reduced, so the end diastolic volume will be increased. So there will be stretch of the mitral annulus and the regurgitation will be high. So the halothane produces the bradycardia, maintain the systemic vascular resistance. So it should be avoided in the mitral regurgitation. So the last question, what percentage of desflurane is present in the vaporizing chamber of a desflurane vaporizer? If it is pressurized to 1500 mm of mercury and heated to 23 degrees centigrade, it is 100%, 85%, 65%, or 45%. So Pankaj, poll please. So Pankaj Mitra has done this calculation. So you have a little bit confusion. Yes. So they have selected all answers equally. That means they don't know the answer. They have doubt about the answer. So the answer is 45%. So desflurane is unique among the current commonly used volatile anesthetic because of its high vapor pressure of 664. Because the vaporizer is pressurized to 1500 mm of mercury and electrically heated to 23 degrees centigrade to give more predictable concentration. That is 664 divided by 1500, it is about 44%. That means 44% at 2 atmospheric pressure. So when it comes to 1 atmospheric pressure, it is 88%. So with that, we come to the end of this quiz program. So we will meet next week with a case discussion. I thank today's speakers, Dr. Arna Prameswari Madam and Pankaj Kundra sir for their excellent topic. And our postgraduates also, I thank for attending this online quiz regularly. Thank you once and all. Thank you. Shilpa Madam, we will find out.